Well, welcome to this pharmacology review on the drug class H2 receptor antagonist. I'm Dr. Busti, your faculty and host on This Is Why, a show that helps healthcare professionals transform their medical knowledge from the what to the why. The goal here is to learn to understand so that we can apply the things that we learn correctly. Now, the H2 receptor antagonists are like a few other drug classes such as the loop diuretics and the thiazide diuretics. They've been around for many decades and still have a place in therapy. Cimetidine, or also known as Tagamet, was approved in the United States in 1977. And this was followed by Ranitidine in the 1980s, along with Famotidine and Nizatidine. Now, most have gone over the counter. Ranitidine has, many of you know, have been taken off the market after concerns about possible carcinogen contamination in the product. And so that leads us to the first question. Why are we still using these drugs, and why is it relevant to learn? Well, the list goes on, but listen guys, this drug class is available generically, as you heard me just say, over the counter, cost-effective options that are well tolerated for the initial management of GERD and dyspepsia. Having access to some of these basic medicines for patients with mild symptoms is not a bad thing, especially with the overall burden on the healthcare system. So that's good. Now, what medications make up the H2 receptor antagonists? We will focus primarily on generic names. That's what board exams use, what tests predominantly use. However, keep in mind that as with other drug classes, your patient might only know the drug by its brand name. So it's good to know both at times and when it's most relevant. But with this drug class has been around for a long time, we most commonly think of the generic names. And those include Cimetidine, Famotidine, and Nizatidine. As you heard me just say a minute ago, Ranitidine had been taken off the market due to a contaminant that was considered or concerning for being a carcinogen. Now, based on the relevance of why we're studying this class and the medications that make up this class, what are some of the indications and common uses that we find them being used for in real-world clinical practice? And I would like to move to a table that helps us to wrap our minds around it, especially also in the context of other antacids that make up this overall drug category. All right, so you can see from this table, there's a lot of information here. Tables like this and other tools that we present on these episodes are available at thisiswhy.health. So those of you who have access to that or sign up for a free membership, please check it out. You can download these, use these for your own bedside teaching, your presentations, or just for studying. So they are there for you and available for download. But we always try to put things in the context of drug classes, especially if there's more than one that make up a drug category. So the category we're talking about are antacid agents. And these are specifically what we're going to be focusing on in this particular topic review, are the histamine 2 receptor antagonists, which make up the first section up here. Okay. The second or middle section that you see here are proton pump inhibitors, or known as the PPIs. And then the third is a newer member of the group or category, and that is the potassium-competitive acid blocker, singular, vonoprazan. So it's good to learn and see where these drugs used, where they're not used. So if you look then by the columns, you can see that goes from left to right. We have GERD, dyspepsia, peptic ulcer disease, H. pylori, and then more concerning symptoms like erosive esophagitis, duodenal ulcers, hypersecretory conditions like Zollinger-Ellison syndrome, and then also lastly, acute GI bleed. So it's nice when we have options that we can use both in the inpatient and outpatient environment. And the H2 receptor antagonists certainly represent a class of medicines that can be used in there. Now, this list is not exhaustive. For example, we will use H2 receptor antagonists as an adjunct in the overall acute management of anaphylaxis. Is it the end-all be-all? Is it saving the patient's life in that situation? No, of course not. However, we know that there's cross-reactivity of histamine receptors, and people have genetic polymorphisms that make them more prone to certain adverse effects going on in a particular indication. Now, it's not listed on here, but I just wanted you to know this is not meant to be an exhaustive list of everything possible. There are other situations like anaphylaxis where we would use the H2 receptor antagonists. So you can see these drugs are largely used for, again, GERD, as I mentioned, dyspepsia. Again, that can be a little bit of GERD-like symptoms or gastritis, basically indigestion, okay, irritation, mild symptoms. Patients are outpatient. They're not usually very sick. Peptic ulcer disease, this was an option, obviously more relevant, especially also duodenal ulcers. More relevant back in the day when we didn't have as many options. Having something is better than nothing. We will see when we go over the topic review for PPIs in another episode that those drugs are more effective at increasing the gastric pH above 4 and maintaining it above 4 and even getting patients above 6, which can be very relevant for an active bleeding ulcer. Now, one of the indications that you don't see indicated on here is the indication H. pylori. That is where the proton pump inhibitors and the potassium-competitive acid blocker are predominantly being used. Now, you will see things like hypersecretory conditions, acute GI bleed listed for, in particularly Famotidine, which is also available parenterally. Now, we used to have Ranitidine on the market, which we could also use, but that is now gone. So having drug therapy options that are, again, available generically, over the counter for outpatient use, but also parenterally for inpatient administration is very helpful to clinicians in clinical practice, especially in areas where maybe we don't have full access to all resources. Okay, that was a lot. So then how then do these medications, along with their indications, connect with their mechanisms of action? And so I'd like to take a moment and talk a little bit about the basic anatomy, because I think it helps us to understand some of the medical conditions that we're dealing with and how we're treating them and the response to treatment that we're looking for, because that helps guide our therapeutic decision making of, do we need to switch them to a different drug class? When do I stop using this? When is it effective? So we see the basic gross anatomy, and then we'll step into the cellular anatomy and physiology where these and other antacids work. Okay, let's jump into the anatomy. I'm a firm believer that when you learn a disease state, drugs and pharmacology, that you understand the context of where these drugs are working, also the anatomy they're impacting for the indications that you're using them for, because that guides us. It guides us to understand, is the drug getting to the site of action and exerting the desired pharmacologic effect? And if not, why not? Okay. On top of that, it also is helpful to learn anatomy, because if something isn't working right, especially in this context of antacids, there's some bad outcomes. We heard indications like GERD that can eventually lead to erosive esophagitis. You heard a condition called Barrett's esophagus that can be precancerous. We heard the word peptic ulcer disease, duodenal ulcer. The duodenum is part of the small intestine. Why do they get ulcers? And then lastly, why do they develop GI bleeds? What is the deal with the blood flow? Well, that comes back to the anatomy. So it's important to have a framework in the context of the antacids in general. How do they work similar? How do they work different? What conditions are we treating? So that's what we're going to spend some time looking at here now. Please stay with me. It makes sense and it brings everything back together, please don't bypass this section because it is relevant to your understanding of the why. Now, we partner with a service known as anatomy.app. Excellent service. You're going to see some great anatomy, three-dimensional structures. They do a fantastic job. We also provide you a link, a referral to that if you need that kind of service for your own knowledge or studying. Again, we highly recommend it. So let's now jump into the board here and look at the anatomy. So first I want to point out some normal anatomical structures. We have the aorta that's coming off the heart and going to the branches that would go to the upper body and then down to the lower body. You also see there is the esophagus, and it comes down through the diaphragm, and the stomach sits below and underneath, tucked up under the curve of the diaphragm. And the first part of this small intestine, which is the duodenum, is right here. Now, why does it matter to recognize this? Well, the esophagus is where that erosive esophagitis is happening. It's also where patients develop GERD. Well, why do they develop GERD? Well, if we zoom in and then also look underneath, you can see that there's an opening in the diaphragm at this location that is helping you to see where the esophagus enters into the stomach. If that band of tissue or that area gets compromised, then acid from the stomach can move up into the esophagus, which it does intermittently. But then we need to get it out. So if it spends too much time up in the esophagus, it's going to cause GERD, and it can lead to erosive esophagitis and eventually lead to a Barrett's esophagus. Now, the stomach can herniate itself up through this hole and stick out on top at this level right here. That is called a hiatal hernia. And with a hiatal hernia, patients can have ongoing symptoms. And that's why it matters, because if you're not responding, that may be because they need a surgical correction of the problem. Now let's take a moment and let's look at some of the anatomy of the stomach and specifically the blood vessels, because that goes back to GI bleeds and peptic ulcer disease. So here we have, you can see the anatomy of the stomach in more detail. Over here is this spleen. You can see that the aorta is coming down and there's a lot of branches coming off. This is the celiac trunk right here. There's a branch going up, there's a branch going over to the spleen. And so these arteries supply large volumes of blood to the tissue. But you also see that we have the common hepatic artery, and then eventually we get down to the gastroduodenal artery. Now it's a smaller artery, but it's feeding the duodenum, the gastrum, and the duodenum over here. Well, when you have somebody with a duodenal ulcer, and that blood flow is impacted, okay, so you can see down in here, this gastroduodenal artery down here is feeding the duodenum. So if you have a posterior duodenal bleed, those patients can bleed like crazy and die from that. Obviously, if you impact the gastric, the gastroepiploic arteries here in the gastric, you have this, the big curves and the smaller curves of the stomach, and you see all these blood vessels going to it. If we erode through that, then you can cause the blood to leak in there. Well, that's blood coming right off the aorta. It's under high pressure and volume. And so that becomes very relevant to explaining why those conditions become so important for us to manage. Now, let's go to the stomach itself. So when we kind of start to zoom in now, this is where we're going to see the cross-section of the stomach. We're going to eventually zoom in and get to the cells. We have chief cells and parietal cells that make up the lining of the stomach. You'll see here in a second that inside the stomach in this cross-section, there's a lot of folds. And in these folds, you see that can expand. Well, that's so that when we consume food, it can stretch, right? But down at the cellular level, that's where those blood vessels are coming in from that blood supply we were just talking about. But it's also where these cells reside. Now, think about the anatomy of this. So if we kind of zoom in a little bit more, again, you can rotate around and see the stomach in all of its angles. But let's say we put a band around here, or we remove a portion of the stomach to make it smaller. So in gastric bypass, then we remove these cells. Well, if we remove these cells, we can also remove some of the normal physiology. And so these are where patients start to develop problems with B12 deficiency issues, absorption of other nutrients become a problem, but you also change the capacity of the stomach. Okay, so now that we saw the basic anatomy, we're now going to zoom in at the cellular level, and we're going to look at specifically the parietal cell in the context of how do these drugs work after they make it to the site of action. Okay, so now we've zoomed in and we're looking at an image, generic drawing, of the parietal cell. So on this side of the parietal cell over here is the luminal side. Okay, it is the apical membrane running along the lumen of the inside. So there's those folds. On the other side is what we call the basolateral membrane. It's the side that communicates and talks with mainly connective tissue and the blood vessels. So the blood flow coming in, feeding these cells. So again, if you erode down and you got a blood vessel coming in here, you can cause a bleeding ulcer. Now there's a couple components on this image that are important for you to recognize. On the luminal side, you see that we have something called the hydrogen potassium ATPase pump. Is a transporter. This is the proton pump right here. This is the proton pump. Here's a proton pump. You got a lot of them. Now, they're the ones that are outputting hydrogen ions. And when those combine with chloride that are being transferred through, okay, then you form hydrochloric acid. And that's what generates the pH, makes the environment more acidic. On the basolateral side, you see we have a large number of receptors and things that turn on intracellular biochemical reactions. Some that activate, which will turn on acid production. Some that are inhibitory and will reduce acid production. There's a balance. So when you look over here, we have acetylcholine that can bind to a muscarinic receptor via the vagus nerve. That's our parasympathetic nervous system. So when we want to eat or we start to eat food, we go into this fed state. That's a parasympathetic response. That means the acetylcholine levels via the vagus nerve are feeding in on that muscarinic receptor. Then we have gastrin coming from the G cells binding to the CCKB receptors. And then you see histamine right here binding to the H2 receptor. H1 receptors reside in other places in the body, typically associated with allergic reactions. Then we have somatostatin and prostaglandins, which are both turning on inhibitory pathways. So prostaglandins become relevant because if you think about drugs like NSAIDs, NSAIDs are known to cause gastric erosion and irritation. They can lead to ulcers, so can aspirin. How does it do that? Why does it do that? Well, we'll go into more detail in another episode, but in short, prostaglandins are inhibited by NSAIDs. So we block this inhibitory effect. That means we're going to facilitate acid production. But NSAIDs also affect the blood flow in through the basolateral side because prostaglandins, specifically prostacyclin, is known to be vasodilatory. So if we wipe that out, we reduce the perfusion coming in. We also reduce the inhibition by the prostaglandins on the parietal cell, and we create an environment or milieu that favors erosion and ulceration. So when you understand some of these basics, then the drugs begin to make sense. Well, what if we want to neutralize just the acid. So you're just having some dyspepsia and digestion, and you want to solve it quickly, right away. Well, the easiest thing that you can do is grab the antacid, over-the-counter antacids like Tums, Maalox, or Mylanta, and just take a good swig, Gaviscon, all those they will neutralize the gastric acid almost immediately on contact, okay? Now, the problem with that is that it's not long-lived. It's a short effect, okay? That means you'd have to keep repeating the doses throughout the day, which is not feasible and could expose people to other things that you don't want them to be exposed to. Too much calcium, too much aluminum, all these things, magnesium. They cause side effects. So it's not a very effective agent, especially if you have gastric ulcer and need healing. So oral antacids like Tums, Maalox, Mylanta are helpful quickly, but they don't serve for treating underlying problems. That's why we don't see it for H. pylori. That's why we don't use it for ulcers. If you want to get more acid suppression, the next easiest option is the H2 receptor antagonist. It's available, again, many times over the counter, and when you give this drug, you are blocking one of the receptors, not all of them, one. And so you will block this activation, which will slowly reduce some of the hydrogen ions. But like I said, it doesn't eliminate all of them. You still have other things turning on the proton pump. And so over time, the use of H2 receptor antagonists can lead to a condition or development of tolerance, breakthrough acid production. Because you are also not fully suppressing all of this hydrogen ions, you are not generating the gastric pHs above 4 for a longer period of time that's needed to create healing, like a PPI can, or like something like a potassium-competitive acid blocker can. You have to do something else. It's not going to work. That's why we want to be careful that if patients are not improving, at some point, we have to change and adjust the medications around. So how did we do that? How did we overcome that? Well, that's where the development of the proton pump inhibitors came, and as well as the potassium competitive acid blocker, okay? They work at the proton pump. It doesn't matter what turns on the cell. It doesn't matter what's triggering it, what intracellular biochemical reaction, it doesn't matter. At the end of the day, it blocks the final movement of those hydrogen ions out into the lumen. And so obviously they're more effective. Now PPIs do that in an irreversible manner. That means they form a covalent bond with the proton pump, and they're there for the life of that pump. Now, thankfully, parietal cells and your gastric mucosa are turning over every couple days. So once you've administered the medication, it may be gone from the blood, but it is stuck on that proton pump for the life of it. That's good. That generates greater acid reduction, reductions in production of it. It makes the gastric pH more alkaline, achieves those goals of greater than 4, and definitely can get up to greater than 6, where if you have active bleeding, you can facilitate some coagulation. It also avoids, there's no tolerance. I mean, it's just check boxes. It's great. It also allows for once a day administration. Now, what about the potassium-competitive acid blocker? Well, yes, it works on the same proton pump, but it competes in a different location, and it's a competitive inhibition. But it's a pretty tight competitive inhibition. It has a pretty decent binding potency, if you will. And so the duration can be greater than 24 hours. In fact, it also works on basal acid production, which can be very helpful when you need to heal, especially at night. Now, sometimes we will use combinations of medicines together to maximize the effect, especially in very difficult to treat patients. But these two drugs right here, drug classes, are the ones that are going to exert the effect to provide treatment for H. pylori over a 2-week treatment. They're very effective for treating peptic ulcer disease and duodenal ulcers, especially if they're actively bleeding, because you've got to get that pH above 4 and specifically above 6. So I hope that brought together how the drug classes kind of interact and work with each other, how they're similar but also different in many ways. Okay, so now that we have solidified our understanding of the mechanism of action and, the anatomy that is very relevant clinically, we need to ask ourselves a little bit about the pharmacokinetics and some of the other aspects of pharmacodynamics that guide the way we use these drugs. So like before, we have another table. I recognize that this table, especially those of you watching this video, that the information can be a little small and hard to read. Again, this table is available at thisiswhy.health for you to be able to download and use and study. But regardless, I'll talk to you and walk you through some of the basic parameters. And one of the things that we want to talk about briefly is when we look at ADME, absorption, metabolism, distribution, elimination. Metabolism and elimination a lot of times kind of get lumped together. Distribution may or may not be relevant. We obviously need the drug to distribute to the right tissue. That's not usually a problem in this case. Overall absorption, right? So this is where when we administer a medication, especially by mouth, how much of it makes it into the circulation? Obviously, if we have a drug that we can administer IV, then 100% makes it in because you're infusing it directly into circulation. So the bioavailability of famotidine given IV is 100%. However, when you look at its oral administration, it's 40 to 45%. So more than half of the drug never makes it into the body. It means it's being eliminated in the stool. Now the other H2 receptor antagonists like Cimetidine and Nizatidine have a greater bioavailability. At the end of the day, does it make a difference? It does influence, in part, the frequency of administration, and that's the so what, who cares part. So why do I learn this stuff? Here's why. When you look at the bioavailability and you put it in the context of the half-life, which you can see that is relatively short, especially compared to the PPIs and the potassium-competitive acid blockers, which are over 24 hours, those allow for once-a-day administration. However, the H2 receptor antagonists have to be dosed twice a day. They're also known to be competitive inhibitors of the histamine receptor that you heard in the mechanism review. And so when you have competition or non-covalent binding, the drug doesn't stick around as long. It doesn't exert its pharmacologic effect as long. And so when you add that with renal elimination, this drug with a short half-life, poor bioavailability, you've got to administer it more than once a day. So in most cases, patients are on it twice a day. If you're using it once a day, it's probably in the context of a patient on another antacid like a PPI or a potassium competitive acid blocker, and you're using it at night to supplement as an adjunct to basal insulin, basal acid production. So that's where you're going to see it used if it's that way, or intermittent patients that have intermittent symptoms, right? That's, again, outpatient management. Now, the last thing that I wanted to point to is the metabolism. These drugs are renally eliminated, but again, many drugs are metabolized. A lot of the metabolic pathways can either be for activation or inactivation, or sometimes to make the drug more water soluble for elimination. In this case, when you look at these drugs, many of them are secreted into the kidneys by transporters, and particularly OAT transporters are some of those. Now, Nizatidine, it's clean, all right? That makes it easy. But Cimetidine, okay, which has been around the longest, has got probably the worst profile. So when you think about of the agents that you want to try to maybe avoid, especially as it relates to drug interactions, Cimetidine is that agent. You can see that it interferes with 1A2. It interferes with 2C19, 2D6, maybe a little bit of 3A4. Again, not strong. It is a substrate and sometimes is used by that, but it's also a weak inhibitor, particularly a weak inhibitor of those. So it can be associated with some drug interactions. There aren't a lot of substrates of 1A2, thank goodness, but there are a few, okay? And so it's just relevant to keep that in the back of your mind. So again, not greatly absorbed, but dosed twice a day, which compensates for that, especially also in the context of its short half-life and competitive inhibition. Now, when we step into some of the indications a little bit tighter, we need to think, okay, well, how long are we going to use these drugs? Remember, these are largely for mild cases of GERD, dyspepsia. Many times the patients are treating themselves. They've looked up information on the internet and they're self-treating and self-diagnosing. That's not always good, right? Because they may misunderstand and misinterpret information. They may not also know how to quantify their own symptoms. And sometimes we blow off things. But you can see for these indications that we're looking at as short as 14 days, again for dyspepsia, over the counter. We don't want patients going much longer. If their symptoms are not improving within the first 2 weeks, then probably something's wrong. They're treating the wrong condition. What other conditions could there be? Well, don't forget that there is about a third of patients, especially women, who can present with a heart attack and their symptom is not chest pain. It could be indigestion. So, I mean, that's happened numerous times where patients come in with belching, burping, reflux, indigestion, and they're having a heart attack. Or they're having ischemia. So we don't want to have patients ignore this. So we put limitations on our recommendations in part to guide people to not do things and misdiagnose and treat themselves. They need to follow up at some point. You can see with the other ones like GERD and some peptic ulcer disease, you got to use them for weeks. These drugs, as we heard, do not typically raise the gastric pH above 4 and maintain it the same duration as a PPI. And so therefore they're not going to be as effective for that gastric healing. And again, we don't want to leave things untreated, especially GERD, where patients can eventually start to develop Barrett's esophagus, which is a precancerous condition. Okay, so this leads us to the next thing that we need to talk about, which are common side effects or adverse drug events that sometimes happen with especially longer use of these medications. Intermittent PRN use, probably not as big of a deal, although there are some cases where it can be. And that is where certain components in our nutrition or drugs that are dependent on a gastric pH that's more acidic in order for it to be absorbed. One of those is vitamin B12. So obviously the more that you reduce the gastric acid production, the greater the impact that it could have. We do have binders that carry B12. There's also intrinsic factor that's involved. And these help deliver B12 eventually to the small intestine where it will be absorbed. But it's got to maneuver through this process through binders and intrinsic factor to get there. And that process is in part due to acid production. You can see a small amount. Now this would be relevant especially in a patient who's vegan, like a true vegan, not eating or ingesting anything that is an animal-based product. So they actually, patients who are vegan have to take supplements to actually be healthy because they are deficient and they can. And that can lead to long-term deficiency, which not only can cause a macrocytic anemia, but can cause a demyelination of the posterior column of the spinal cord and cause various neuropathic deficits and issues that patients can start to experience. Now, there's also the gastric pH, and this is where drug-drug interactions also need to be considered. So again, any drug that lowers the gastric pH or makes it more alkaline, okay, is going to impact some of the absorption of acid-dependent drugs. For example, tyrosine kinase inhibitors like erlotinib, dasatinib are known to be dependent on that. Atazanavir, that's a protease inhibitor for the treatment of HIV. Ledipasvir and sofosbuvir used for hepatitis C. Itraconazole capsules, not the solution. So if you think about those drugs that I just listed, it's not really normal to be on those medications in the sense, like if you're on them, you need them. And you need to make sure they get adequately into the body. We do not want things delaying the absorption of these drugs. This can be catastrophic to the patient and produce bad outcomes. So we have to keep that in mind. That is also true for other antacids. Now, cimetidine, as I mentioned earlier, has two issues. One is, yes, it certainly affects the gastric pH, but the other thing is that cytochrome P450, it's a weak inhibitor of cytochrome P450, which is a phase 1 metabolic pathway, 1A2, 2C9, 2D6, and 3A4. Well, there's a lot of drugs that are substrates of that. And so that's very relevant to keep in mind. Number two, and less commonly thought of, but is relevant, okay, is that cimetidine can inhibit gastric alcohol dehydrogenase. You're like, so what? Why does that matter? Well, here's the why. If you drink alcohol, you can't metabolize it as efficiently as normal. So theoretically, the amount of alcohol you can metabolize per hour is going to be decreased, and so you could theoretically accumulate more. And so that can become relevant. So it's a unique mechanism. It's a unique to the medicine itself. And these are commonly good questions for board exams and tests that people like to ask. All right, so now that we reviewed mechanisms, indications, side effects, some basic drug interactions, what about monitoring parameters? Well, first of all, you heard earlier in the mechanism, there is a risk of tolerance. That means their symptoms are just not going to get better. Okay, so we need to move on to something that's going to overcome the tolerance. The next thing is consideration of labs. Now, the one lab you want to consider is the serum creatinine. Why? Well, remember I told you in the pharmacokinetics that part of the elimination is renal. So as the renal impairment occurs, the patient needs to be on a smaller dose. So typically when the creatinine clearance gets less than 50 mLs per minute, we want to make dose adjustments. Okay. Now, the second reason a creatinine can be relevant is that some of these drugs can compete with the creatinine's movement or secretion into the proximal renal tubule. That competition can raise or increase the serum creatinine lab level. That's not causing renal damage. It's not an acute kidney injury. It's okay. It's almost expected, especially with cimetidine. That competition with it at the proximal renal tubule. It can be a problem. So just keep that in mind as you're monitoring their symptoms, the risk of tolerance, and in particular the lab, serum creatinine. Now, what about B12? Again, if you're using it long term, most of the duration of these indications for this particular class of antacids, you're not going to see it. It's very rare. You'd have to be on it for years to deplete it and not be ingesting or taking supplements. Most people are, or at least get exposed to it, so that's not usually the case. But obviously if you have an undifferentiated macrocytic anemia, where your MCH, MCB, all those things are abnormal in a pattern of a macrocytic anemia, then you can give it consideration. All right, now what about some counseling? Well, we talked a little bit about drug interactions specifically for patients on tyrosine kinase inhibitors, itraconazole capsules in particular. Ketoconazole also historically needs an acid environment, but really it's itraconazole. We don't use ketoconazole very much anymore. We talked about atazanavir, the protease inhibitor for HIV. Those are relevant medications. So we need to counsel them that if they get started on any medications like those, in the future, or just pay attention to it. They need to alert you, especially if they're going to be on cimetidine-based regimens. Now, cimetidine, we know, also impacts alcohol dehydrogenase in the gastric lining. Well, that can cause theoretical increases in alcohol levels or decrease the metabolism. The other thing to keep in mind is the duration. If patients want to use these, so if we're in the outpatient, they tell us they're using them, or they come and buy it from you, you're a pharmacist, or you see them and they want to get it, fine. But remember, over the counter, if they're using it on their own with self-diagnosed treatment plans, they probably shouldn't go longer than 2 weeks. If their symptoms are not getting better with it, something's wrong, or they're using the wrong medication. So they need to have follow-up and reevaluation. All right, well, at this point in many topic reviews, there's a lot of things to try to keep track of. This isn't too bad of a drug class, but remember, we want to understand the why, because it changes the how. What is the how? How to apply it to a patient, how to manage a patient in the real world setting. We can talk about this stuff all the time. You can read about it, but when you're dealing with it in real world clinical practice, the how becomes very relevant. Well, in order to be able to do the how, you better understand the why so that you can do it right. So don't just know it, but let's focus on getting it. All right, we put these topic reviews along with other ones in collections, playlists. Those are available at thisiswhy.health for you. In addition to the tables that we use, diagrams, things like that, those are available for your reference, for studying, or again, you can use them for your own teaching. They're there to help you, help others. That's the goal here, help each other out. We also release newsletters and updates, so if you want to keep up to date on other topics and follow certain playlists, then you can do that. All right, so the H2 receptor antagonist, great initial treatment option for mild GERD and dyspepsia. Patients are usually outpatient. They're available over the counter, many of them are, and they're generic, so they're cost effective. Now, overall well tolerated, not too bad to use, but you gotta use it twice a day, renally eliminated. The exception sometimes is cimetidine. It causes some drug interaction. Sometimes it can be a little problematic. So I hope you found this drug class review and pharmacology review to be helpful, and we'll see you next time on the next show of This Is Why.